Good afternoon, ladies and gentlemen. Thank you so much for coming over here and taking some time out from your Friday to attend this talk. This topic is very important to me, basically about colon cancer and prevention mainly. As you all know that, colon cancer is one of the commonest cancers in North America, only third commonest. However, it is the only one out of the top three that's very preventable. And as we go and I got these slides from American College of Gastroenterology. They're a little bit dated from 2021, and there's one or two things over here that I'll sort of correct as we go along. So, as you can see that colorectal cancer is the third most common cancer behind lung and breast cancer. And regular screenings can prevent colon cancer. The key word is prevent. And it can be prevented by removal of polyps up to 90%. And when we say 90%, you would think, well, it comes out of polyps and you remove the polyp, why is it not 100%? Well, some of the polyps can already have some cancer growing in them. And as you remove them, the base of what has been removed may have some cancer cells. So that's how it's not 100%, but it is pretty much 90%, which is actually pretty good. All right, so some of the common cancers, breast cancer and prostate cancer, they are also detectable by screening, just like colon cancer is, but they're not preventable, because you can't really tell and take care of it just by screening. You have to do something about it. Screening test colonoscopy can prevent colon cancer. All right, so colon cancer. When we say colon cancer, we mean cancer of the large intestine. Large intestine basically consists of two major parts. One is the colon. So we're starting off here on the right side, bottom of the right side. This is the colon. It starts right above the appendix, goes up on the right side, then goes across under the stomach, and then down on the left side all the way up to here. I hope you can follow the arrow over there. And this part is the rectum. This is, for our treatment purposes, we treat it as slightly different, but together they form the large intestine. And when we say colonoscopy detects cancer, it detects cancer both in the rectum as well as the colon. So how does the colon cancer start? So as you can see over here, this is just sort of a cartoon drawing about how small growths called polyps can start in the inner lining of the colon. So if you just kind of humor me and imagine the thickness of the colon wall, it has 5 layers in it. The innermost layer is called the mucosa. And that's where the cells start becoming abnormal and start what we call proliferating or becoming bigger. So initially it starts off small over here, bigger, bigger, bigger. And then not only does it get bigger in size, but also starts changing the characteristics of the cells so that they take a life of their own and start becoming towards the cancerous cells. And then you see over here, the cancer cells start invading the lining, the inner lining, go into the deeper layers, and then eventually goes through the layer and sometimes even what we call spread out or metastasizes to local organs as well as distant organs through the blood. So basically what this growth is a clump of cells that initially are harmless. So polyps, we call polyps for all growths, all small growths that come in the colon, we call them growths. Some of them have potential of becoming colon cancer and some don't. But when we go in and we look at the polyps, we can't really tell 100%. So as a matter of rule, we remove all the polyps. We don't ask questions, we shoot first and ask questions later. So, and then we look at them, and then based on the nature of the polyps that's examined under the microscope by a pathologist, we determine whether they had cancerous potential in them or not, and decide when the follow-up is going to be. So if there is a polyp that had no potential whatsoever, and the person does not have high risk, like a family history or previous history of polyps, they can go for another 10 years without having a colonoscopy. And if they do have a potential, then based on how aggressive they were, we recommend anywhere from 3 years to 5 years, or even earlier sometimes. All right, so here's some gross pictures. So I know there's food with you, but just bear with me. So here's what different polyps can look like. So polyp can be like a mushroom. It can be like on a stalk like this. And it can be flat, and it can be spread out. Or it can be just a little nub like this. Generally, the polyps that are on a stalk like this are much easier for us to take out, because you just put a lasso around it like an electric wire and cut it off, and then it just leaves a very small space, and most likely if you have a clean stalk like that, usually there's no cancerous invasion in there. But flat polyps like this, it takes a little bit more doing to get these out. Now, some of the polyps can be difficult. And if you look at this picture right here, behind you see these folds, which are normal part of the colon. But you see another fold over here, which kind of looks like a fold, and there's no obvious growth on it, but there's a depressed area over here. And this depressed area is actually a malignant growth. So there are different kinds. So you have to be on the lookout and just take your time in looking at the findings of the colonoscopy, and not just ignore stuff like that. Now in this picture, the difficulty in this polyp is pretty obvious. Everybody can see this polyp. But what's the difficulty? The difficulty is, you know what this is right here, this black thing? This black thing is actually the colonoscope.
It's a what?
This is the colonoscope. This is the instrument we use. And why are we looking back at because we only see forward with the colonoscope, right? So why are we not looking forward, and why are we looking back? So we are seeing the colonoscopes. The colonoscope may be turned around. Why is it turned around? Because this is a thing called retroflexion. So we turn the colonoscope around to see behind the fold, because if you're looking at the fold from the front, the polyp may be behind it and you can miss it. So that's why we look behind the folds to make sure that no polyps are missed. And then we use some other techniques to visualize the polyps and see, different kind of lights that illuminate the vasculature and the nature of the polyps to help us detect better. So like I said, you can see that in this cartoon, there's a colonoscope that's kind of going up, because we're going backwards. So we're going up in the rectum, and there's a few twists and turns over here that and that's why we put people to sleep, so that they're not uncomfortable and cramping as we're going through the twists and turns. Some other pictures of polyps, and when we remove them, you see this. So this is a polyp. So this is a polyp right here, and it's removed, but you see all this blue stuff in there. So why is there blue stuff in there? Because this was you can see it's kind of spread out polyp, and it's the whole base of it is removed. So it's not like a little stalk, we've removed the whole base, but we can't be 100% sure that there was no little nub left behind that may still have cancer in it. So, therefore, we mark this spot with a tattoo. So that if on the pathology report we find that even in the edges of the polyp, if the edges of the polyp were clear of any kind of suspicious cancer cells, then it's fine. Then you don't have to go back. But however, if the edges of the polyp had some cancerous cells in them, then you have one of two options. You can either go back with a colonoscope and try and see if you can, or go back in 6 months or 3 months and look at that again, make sure nothing's growing out of it, and shave it a little bit more. Or if you feel that this is something that cannot be done with a colonoscope, excuse me, then you can have the surgeon take care of this. But it would be very easy for the surgeon to detect it if you tattooed that area. So he doesn't have to go looking around and exploring a lot. He just knows where it is and take that out. All right, so the risk of colon cancer, there's sometimes a perception in some people that, it's predominant in either males or females, or men get more colon cancer than women, which is not exactly true. There's very, very small difference. They're almost equal. So there's a 1 in 23 lifetime risk in men and 1 in 25 lifetime risk in women. So you can see that it's not that much of a difference. And for some reason, people who are born after 1990 have a little bit more risk because of changes in lifestyle and the advent of computers and everybody just sitting around at home and not having any outside time and all that. All right, so if you have a family history of colon cancer, you're in higher risk than average. If you have a history of polyps in the past yourself, you're at higher risk of developing them again. Likewise, cigarette smoking. We all know how bad that is. Obesity is bad, and that's why all this sedentary lifestyle that's leading to obesity, not good. For some reason, if you've had a gallbladder removed in the past, we don't know what the exact causation is, but there is a definite association in people who don't have a gallbladder anymore. As I mentioned, physical inactivity. People who've had abdominal radiation, either they've had multiple CAT scans for whatever reason, or x-rays, or they've had radiation for other cancers, like prostate cancer or uterine or whatever other cancer, then radiation collateral damage to the intestines can cause increased risk for colon cancer. There is also a definite association between cancer of the uterus and ovaries before age 50 for having a higher risk of colon cancer. And you all must have heard of these conditions called ulcerative colitis and Crohn's disease. They're basically conditions in which there is inflammation of the colon and intestine, and people who've had them for a long period of time have a higher risk of having colon cancer. And in North America, the African American race have a slightly higher incidence of colon cancer than others. All right, so what is the most common presentation of colon polyps and colon cancer? Can anybody venture a guess?
Bleeding.
Okay, that can happen. Anybody else?
Never getting a colonoscopy.
That's right. So basically, no symptoms. No bleeding, no pain, no weight loss, no nausea, vomiting, no symptoms. So that's the most common presentation. However, if any of those symptoms arise, it's just human nature to kind of dismiss it and say, if I had a little bleeding, I was constipated and I was just strained on the stool, and maybe it's just hemorrhoids or something like that. It's okay to miss hemorrhoids, but it's not okay to miss colon cancer. So that's why it's always good to get it checked out. All right, so again, so should I wait for the symptoms to develop? No, of course not, because then it may be a little bit late. All right, so what are the symptoms going to be? Maybe blood in the stool, you've had regular bowel habits forever, and then all of a sudden your bowel habit changed. Change in shape or size of the stool, you have some pain in the rectum, abdominal pain, weight loss for no reason. Everybody knows it's so hard to lose weight. All of a sudden you lose 20 pounds, you're like, man, I must be doing something right. No, the opposite. Or if you feel just, that you're getting tired and you go to your primary care doctor and they say, well, you have anemia. Why do you have anemia? So that's suspicious. So you got to look for, because one of the most common causes of anemia after a certain age is blood loss through the intestine. And one of the most common causes of blood loss through the intestine is colon polyps or colon cancer. So what should you do? Get screened, of course. All right, so now how do we get screened? So there is one-step screening and multiple-step screening, or two-step screening. So in all the screenings, and we'll talk about the various kinds of screening, colonoscopy is the one-step screening that not only detects but takes care of the problem. In all other tests, there is a second step. And what's the second step? A colonoscopy. All right, so there's a bunch of other things that we can do, which is certain stool tests. So a hemoccult test or a FIT, fecal immunochemical test, basically detects evidence of blood or heme in the stool. As well as nowadays, you must have heard of another test called the Cologuard. And the Cologuard detects DNA of polypoid cells in the stool, which is also a test that is used for screening. Now, in some of the people who don't want to get either any of those tests, some other options are available which are not as good, non-invasive, as we say, which are not a colonoscopy. So a CT colonography is basically a CT scan, which pays more attention to the colon, and a colon capsule. A colon capsule is a capsule that has a camera in it. So basically, you just swallow the capsule and kind of goes along and takes pictures. And there are, of course, limitations to it. Number one, the kind of prep that you took. And because it doesn't make a video, it takes pictures. So it takes pictures at certain intervals after every few 30 seconds or whatever. So you can imagine that between one picture and the other picture, it may have moved a distance and missed whatever is in that part. So even though it is an option that's available, if nothing else is done, but it is not the best option. All right. So if we go back, well, let me see what's the next one. There you go. So the one-step test versus the second two-step test. So if you do any kind of test that require a colonoscopy afterwards, if that test is positive, is a two-step test. So both the blood test, the blood detection test in the stool, as well as the DNA detection test, which is the Cologuard, first of all, no test is 100%. So it's not 100%, detects all the cancers, and it can have false positives and it can have false negatives, small percentages. However, if you have false positive, you still need to have a colonoscopy. Or it's positive in any way, you still need to have a colonoscopy. One of the things about these tests, not the blood test, because that's not considered a complete screening test by in most insurances. However, the Cologuard test, because it's a fairly expensive test, most insurances that provide screening coverage, or like they say, well, your screening is free, and we're going to take care of all of it. It's not going to go towards your deductible or anything like that. They consider the Cologuard as your screening test. So if you do the Cologuard and it comes back positive, your screening test is done. And then when you go and have the colonoscopy, that's not going to be a screening test anymore, because that test is being done because something was positive. So your insurance is going to turn around and say, well, you had your screening test done already. This is to detect what was found. So, and however, if you have the colonoscopy done in the first place without any symptoms, then it is considered as a screening and the insurance pays for it. So that's a thing that sometimes patients do get upset, and they're like, but my screening test was positive. That's why I'm having the colonoscopy. All right. So we recommend the recommendation now, and there's going to be a slide subsequently that says, because this was made in 2021, just after this was made, the recommendations went for everybody all across the board to have colonoscopy at age 45, not just African American people. So African American people, it went to a little bit earlier, age 40, but everybody else with no risk factors, which means no family history of colon cancer and no previous history of colon polyps, should have a colonoscopy starting age 45. And the recommendation is to go up till age 75 by doing screening. That is the first time test. So if you forever have put off the thing and you've never had any kind of test done till age 75, you need or you should have it done. We do colonoscopies till age 80 for people who've had polyps before. So let's say if somebody at age 75 or 74 had a colonoscopy and turned out to have a polyp, we recommend, okay, well, have it done in another 3 or 5 years, and we do it up till age 80. And usually after age 80, unless they've had a very, very strong suspicion for colon cancer or something, we don't do follow-up colonoscopies after that. Yes. So colonoscopy, if you have it done once and it's negative, recommendation, you're done for 10 years. So you don't need to have another one done. Unless you had fun with the prep and everything and you call us and you want to have it done again. But, the other tests, so the Cologuard test, which is the DNA test, you need to have it done every 3 years. And cost-wise, for the insurance, or if most people don't pay it out of their pocket because it's covered, but still, the cost for the insurance is actually the same. If you do it 3 times over 10 years, it kind of comes out to almost the same. Now, some of the other things that I mentioned over here, I don't agree with at all, because a flexible sigmoidoscopy every 5 to 10 years. What's a flexible sigmoidoscopy? It's a shorter scope that looks only in the left side of the colon. Now, way back when, and I'm not going to disclose my age because I'm pretty old as well. When I trained, there was a trend to do flexible sigmoidoscopies and then not do anything else, or maybe do an X-ray of barium enema afterwards for screening purposes. But if you're only looking in the left side of the colon, you're missing 2/3 of the colon. So in my opinion, it really doesn't make sense. And I've told you about the CT colonography, because you can do the CT scan. However, sometimes you can't tell whether it's a piece of stool or a polyp, because it's basically what you're looking at is just black and white or gray. And a colon capsule, I told you the limitations of the colon capsule. There's a blood test as well, but nobody recommends that because that's not really too good. All right, and as I told you, screening for African Americans, actually instead of 45 as it's mentioned over here, it's actually 40. For general population, it's 45. And sometimes if for example, you're not even concerned, but you just find out, oh, a brother or a sibling or a parent or a child had something was found, and now you're concerned. So, go and talk to them. And sometimes in those, if there's a family member, especially if there's a first degree family member at a younger age, you probably want to have some they want to have blood testing done, genetic testing, and you want to have the genetic testing done as well to make sure. There are certain syndromes in which there is not just isolated colon cancer, but it is a bunch of other things like even stomach cancers and cancers of other organs that need to be screened in those certain genetic syndromes. Yeah, so basically go to your doctor, get referred to a gastroenterologist, and these days actually a very good process is what we call the direct access colonoscopy. So you don't need to have a second office visit with a gastroenterologist. You just go to your primary care doctor, and if there's nothing else going on, of course, if there is some symptom going on, you need to be seen by the gastroenterology provider and have it checked out to make sure other things are not needed. But if it's purely a screening or just a history of polyps and you're just concerned that it's time and you want to have it done, there's a thing called direct access colonoscopy. So you just go to your provider and you tell them, listen, it is my time or my age or I had the history and I just want to have it done. And, can you just schedule me direct? And most providers, primary care providers over here now, can get it scheduled through us, just through their office, and you don't have to come to our office. You just come, you get your instructions for the prep. If certain medications need to be held, like blood thinners or anything like that, they give you all the instructions. You just show up on the day of your colonoscopy, and if we don't find anything in the colonoscopy, there's no follow-up. We just tell you right then, it was negative. You don't need to have another one done for such and such years, based on if you're high risk or not. But if we remove something, if we see some polyp then we send it to be looked under a microscope for pathology, and then we follow up to let you all know what kind of polyp it was, what needs to be done, and all that. Thank you so much. Enjoy your Friday.